You've performed a surgical procedure and now you're almost done with it. You have sealed your anastomosis, but now you just want to make sure that there's no leakage. And if there is, you want to provide a channel through which that leakage can come out of the body without harming itself. So what do? You place a drain. A drain is a tube through which that leakage would leak, or it is a pathway that leakage would follow, and that leakage would be connected to a tube or a collection chamber in which it would be collected, so that you can quantify the leakage and assess the success of your anastomosis. Now in this section we'll talk about these drains. We'll see what the various types of drains are, when they are performed, how they are placed, and finally when to remove them. So starting off, now drains are inserted to allow fluid or air that might be collected at an operation site or in a wound. We have talked about this in detail before. Drains actually provide a site through which any material that is being collected in the wound site can be drained off outside the body without damaging itself. Now, the fluid can be anything. It can be blood, serum, pus, urine, or feces. Now, there are three types of drains. We have open drains, which use the principle of gravity. Then we have semi-open drains, which use the principle of capillary effect. And we have closed drains, which utilize suction. A drain can be seen in the figure as well. So there are three types of drain: open, semi-open, and closed. The type depends upon whatever is available and the choice of surgeon himself. So the use of drain depends upon the surgeon's individual preference. We have talked about it before. Now, they're agonist and antagonist for that. Now, protagonists say the drains, they remove intraperitoneal or wound collection of ascites, serum, etc. Now, they provide track for later drainage, and they act as signals for post-operative hemorrhage or anastomotic leak. So these are the favors they give for placing a drain. Now, the antagonists, what do they say? They say that this increases the intra-abdominal wound infection and anastomotic insufficiency. It increases hospital stay and abdominal pain, and it reduces the pulmonary function. So there's some do's, there's some don'ts, there's some pros, and there's some cons. So it's always the surgeon's preference whether he wants to put a drain or not. Now, the usage of drains. So the drains are not used in gastric, duodenal, small bowel, appendix, and biliary surgeries. As I mentioned in the beginning, the use of drain in gastrointestinal procedures now is questionable. So they're usually not used in gastrointestinal procedures. In randomized controlled trials, it has been seen that they're not even needed in colorectal surgeries, in liver surgeries, and in pancreatic surgeries. The only use recommended is in esophageal surgeries, and even in that, it is a level D recommendation, that it falls low on the list. So placing a drain is usually not recommended. Now, there's specific type of drains used in specific parts of the body. Let's see what these specific types of drains are and how they are used. First of all, we'll talk of the chest drain. Here you can see this is the pleural cavity. The parietal pleura in black, the serosal pleura in black, and in between this is the pleural cavity. This is where a chest drain has been placed. So what does the chest drain do? Obviously, it would collect any fluid that has been collected within this space, or any air that has been collected. Now it is indicated for a pneumothorax, that is air within the thoracic cavity, for pleural effusion when there is fluid within the within the pleural cavity, and hemothorax, that is when there is blood within the thorax itself. So three indications: a pneumothorax, a hemothorax, and pleural effusion. Now it is usually connected with an underwater seal drain. So this is an underwater drain and this has been sealed. So it is connected, this chest drain is connected to an underwater seal drain. And why is that? It causes the air to leave the pleural cavity but not to be reabsorbed. The air that leaves the pleural cavity, it cannot be reabsorbed because of this being a watertight sealed, this being attached to a watertight sealed drain. Now, during respiration, the meniscus of the fluid should be swinging. This meniscus of the fluid should always be moving when the patient is respiring. So, when the patient is respiring, this is moving and you know your drain is in the right place. Now, suction can be applied to the ventilating tube, and about 10 to 20 millimeters of suction is sufficient to drain whatever material is present within this pleural cavity. Now, T-tube drains. You must be knowing where the T-tube drains are used. T-tube drains are used for pancreatic surgery whenever there is manipulation of the gallbladder. T-tube drains are used. So, insertion of the T-tube allows the bile drainage while the sphincter of Oddi is in spasm. So, sphincter of Oddi is on the major duodenal papilla of the second part of the duodenum. This is where the bile duct releases its bile. This is the sphincter is present at the exact site from where the bile enters the intestine. So after the manipulation of bile duct, the sphincter of Oddi is in spasm. So in order to relieve the spasm, this is the area of the sphincter of Oddi. This is the bile duct. This is the second part of the duodenum into which the bile duct is opening. Now, in order to relieve the spasm of the sphincter of Oddi, this T-tube drain, this T-like drain is placed. Now, this T-tube drain, it causes the drainage of the bile duct, of the bile itself. Now, as the sphincter relaxes, the bile drains through the normal channel, that is the drainage through this T-tube, it decreases with time. Now, the conversion of lumen limb of the T into a gutter is usually assists with choleoresis. If you convert this luminal limb into a gutter, this usually assists in the this is converted into a gutter, this helps in the drainage of the bile itself. Now, there's certain other techniques as well. We have image guided drainage. In image guided drainage, the drain is inserted under an ultrasound or CT control. Now, a pigtail end is used to prevent the drain removal. That is, a swollen pigtail end is used so that the drain cannot be removed accidentally. It uses less invasive methods and manages the primary and secondary fluid collection. So these methods are less invasive because they're under image guidance. So a lot of structures are not being damaged and they can help in the drainage of primary and secondary fluid collection in anywhere in the body. In sepsis, they're used with intravenous or oral antimicrobial therapy in an attempt to improve the patient's outcome. So here you can see this is an image guided drain. This is a CT scan of a patient and this is an image guided drain being placed, and through this drain the fluid is being collected and drained out of the body. Now, how do you remove the drains? You have placed the drain, but now when and how do you remove the drains? So removal of the drain, if used for perioperative bleeding, it should be removed after 24 hours. For example, in thyroidectomy, you'll know your perioperative bleeding within the 24 hours. Now, if it is used for serous collection, it should be removed after 5 days. For example, in mastectomy. Now, if it is used due to infection, it should be left till there's minimal drainage. That will give you an idea that the infection has subsided. And if it is used for colorectal anastomosis, it should be removed at about 5 to 7 days. Now, the common bile duct T-tube should remain in for 10 days. Now, why is that important? Because they provide an alternate channel for the bile to go through. Now, a suction drain, the suction should be taken off prior to drain removal, and the removal of chest drain, the patient should be asked to perform the Valsalva maneuver. This would help you to remove the chest drain and provide suction of any material through the drain itself. So this is important in the removal of drains. So this was all about this section. We have talked a lot and in detail about the drains, the placement, the need and the removal. I hope you liked and understood this section. For further sections, keep watching sqadia.com.